In this research, I was interested in examining the efficacy of an educational intervention to reduce anti-fat bias among clinical psychology trainees. This intervention was guided by CRANDALL and colleagues' attribution-value model of prejudice. The attribution-value model identifies two interrelated factors that increase prejudice towards social groups. One is attributions of controllability. Social bias is shaped by people's perceptions of controllability, responsibility, and blame over a stereotyped group characteristic. The other is cultural value, beliefs that lead people to evaluate social groups in particular ways, for example, by perceiving a social group as lazy or lacking intelligence. Applied to anti-fat bias, prejudice is exacerbated when fat people are attributed responsibility for their weight and when fatness is negatively culturally valued. The intervention challenged misconceptions regarding weight and health. Trainees learned that fatness is not necessarily unhealthy and that dieting is not effective for weight loss over the long term. The intervention also emphasized the prevalence and harm of anti-fat bias, as well as models of health that are weight neutral and inclusive. In a pre-post design, trainees completed measures 1 week before and 1 week after the intervention, and it was found that trainees reported weaker weight controllability beliefs and anti-fat attitudes after the intervention. In fact, weight controllability beliefs mediated the reduction in anti-fat attitudes. Although these findings are promising, more rigorous research designs are needed. There is a need to better understand how these interventions work, for whom these interventions are effective, and what the long-term potential of these interventions are. Nevertheless, the incorporation of interventions to reduce anti-fat bias into healthcare training is an important endeavor for at least 3 reasons. First, anti-fat bias is pervasive in healthcare settings, just as it is in broader society. Indeed, many previous interventions frame fatness as a public health crisis by situating fatness as a disease, advocating for weight loss, or focusing on the health consequences of fatness. This approach may perpetuate stigma. Second, despite its pervasiveness, anti-fat bias is not addressed in healthcare programs. Training rarely includes weight stigma, and when body size is discussed, it's frequently done so from an individualized and medicalized perspective. Third, anti-fat bias is harmful. It has serious physical and psychological health consequences. Anti-fat bias is a pressing social issue. Educators have a powerful role to play in raising awareness, building social consensus that weight bias is not acceptable, and destigmatizing fatness.